So I am excited to chat with you guys today about dystonia and dyskinesia. And this is sort of an informal lunch and learn. So we have an hour together, and I will say both of these topics we could dive into probably a full day talk about. So what I'd like to do today is really just share some of the key things that I have learned along the way. I have been practicing since 2005, and I specialize in working with people who have movement disorders and degenerative disease, specifically Parkinson's. And with that can come quite a bit of dyskinesia and dystonia. And I will say this is probably one of those topics I get a lot of questions about, and I also really needed to dive into and sort out not only a better understanding, but what are the things that will help us get good results, because it can be really challenging. Since we do have a short time today together, I'm going to send out a quick pulse check, and I just want you to give me a thumbs up if maybe about 50% of your patient caseload right now is degenerative disease. So you see Parkinson's, MS, ALS, movement disorders that would include these dystonias or dyskinesias. If that's like 50% of maybe your patient caseload, give me a thumbs up. And if it's not, go ahead and give me a thumbs down. That just gives me an idea of kind of where we're all coming from, so I can use our time best. And as you guys are doing that, feel free as well to go ahead and ask any questions along the way. I'll try to answer them as they're sort of appropriate as they come up, and we're kind of having a conversation about these topics, okay? And today, ideally, what we'll do is go ahead and start with some key points about dystonia, and really focus on just kind of two main types of dystonia, because there are several. And then we'll try to break it down and look at it through the perspective of a case study. And talk about what worked for this particular patient and what that, we'll do some demo as to what that looks like. And then we'll do the same for dyskinesia. So we'll talk about dyskinesia and understand kind of where it's coming from and its impact. And then we will also talk about, through the lens of a case study, treatment approaches, strategies you can go ahead and put into play this afternoon when you go back to see your patients, and try and see how they work. I'll try to give you a framework so that you can pick and choose what's going to work best for each patient, because these disease or diagnoses tend to be really unique. So what works for one person or patient can be very different to the next. So try to give you a little framework for problem solving as well. Okay, so it looks like majority of folks are probably have less than 50% of these guys on their caseload. Thank you for letting me know. All right, so then let's go ahead and just start from the beginning. So dystonia, it's actually the third most common movement disorder. And we would define this as excessive or involuntary muscle contraction. So it is patterned, it's repetitive, and it can increase with specific activities. And I would say everyone has a little different trigger. And it can affect any body part. What I'd like to do today is focus on two main types of dystonia, which I would say I see most often. So that is going to be cervical dystonia, where it affects the neck and shoulders. And it can cause a turning, or often we see sort of a head positioning to one side, a little rotated. A lot of times as well, I can see chin to chest, so it brings the head forward. But it is also possible that it could bring the head back. But I would say personally, just in my clinic, I often see a little side bending and rotation, or if it's really bad, I might get this chin to chest, and it's challenging to work out of that pattern. And they may or may not have a tremor with that. If we look at limb dystonia, here it may affect the arm, foot, or leg. So upper limb dystonia is common in an atypical form of Parkinson's, corticobasilar degeneration. And so we see this posturing. So the hand kind of clenches, the forearm kind of rotates, and they may also start to bring the wrist into some flexion. And that could be held kind of at their side, or a lot of times kind of behind their back. We can also see some of this type of a posturing with the hand. And when it's consistently in this type of posturing and kind of hidden behind the back, that can also be an upper limb dystonia. And then we can have a lower limb dystonia. And I'll show you a couple pictures in just a quick sec. But here the toes might be curling and clawing the floor, or that big toe could be pointed up. And that's more like a focal dystonia. But dystonia can also affect the jaw. It can affect the vocal cords. It can affect the eyelids. And I think this is probably, you may notice this, but not think, I know for a long time I did this, you don't really think dystonia, but then those eyelids can blink uncontrollably, remain closed. And then we can also have a general dystonia. Okay, so let's just focus on a couple. For time's sake, we're going to start with cervical dystonia. So here's a great example. And I would say it's a pretty common picture that I see in my office. One shoulder tends to droop down. We have the head kind of postured, maybe side bending away, rotated, or again, it could really be held chin to chest. So these are some of the clinical things we might see when we meet a patient face-to-face with cervical dystonia. And then these are some of the things we might see if someone has a foot or lower limb dystonia, which can be very common with someone who's been diagnosed with Parkinson's and is on L-DOPA therapy. So we can start to see plantar flexion, inversion, some toe curling, or just kind of the main toe, the second toe, in the foot, especially when we have them weight bear and stand, or if I really challenge their balance. So now maybe they're standing on foam, or they're standing on an unstable surface or an incline, or walking as well, can really like exacerbate and draw that out. And that might just kind of clue me in to what we might be working with. But they can also have a focal dystonia where the toe starts to pull up and away, and we start to see that type of a presentation. Okay. So there are different causes for dystonia, just to give you a little bit of background, because it will help guide your treatment, but I don't want to spend too much time on it. But obviously there's isolated or primary, where it comes from an unknown origin and it's the primary diagnosis. Like the cervical dystonia is their diagnosis. They don't have any other diagnosis. And it's a clinical diagnosis. They would look to see if there's any other central nervous system or peripheral nervous system lesion. And if those are negative, and this typically would appear in adulthood, and then we may just have like a cervical dystonia, or maybe a focal dystonia, like a runner's dystonia or something like that. And then we can also have an acquired or secondary. And I would say this is the majority of what we see in our clinic. And it's a symptom of another neurological disorder. So about 90% of our patients have Parkinson's. And so we see quite a bit of dystonia as well as dyskinesia in the office. And not every person with Parkinson's will get one of those motor symptoms or secondary diagnoses, but it is more likely with that diagnosis. We can also see them in these cervical dystonias or other forms of dystonia in Huntington's due to medication, and then we call that tardive dyskinesia, or some other genetic disorders that are more rare. It is, again, a clinical diagnosis, so a movement disorder specialist is really the best person, since they see the majority of these folks day in, day out, to diagnose it, and to also help with treatment. So they're looking for some of these movement patterns, postures, like we are in our motor control evaluation and clinical evaluation. And then they'll run some tests to rule out other things like stroke. They may do a DAT scan, other tests to rule out problems. And then just sort of a quick hypothesis of what's causing dystonia. The thought is it's a reduced inhibition that results in basically a constant contraction. So if the cells that are supposed to be inhibiting in the brain, the nervous system from telling the muscles to contract aren't working as well, then we get overexcitability. Okay. So abnormal connectivity, dysfunctional network, and this constant contraction. So if we have excessive excitability, you can kind of start thinking where our treatment philosophy may go to. How can we calm the nervous system? How could we create some inhibition versus excitability? And if we look at specifically Parkinson's, and this as a secondary diagnosis in Parkinson's, there are some things that could increase that person's risk for dystonia. And that's usually the age of onset. So the younger, the more likely they may have a dystonia, their medication schedule, and whether or not they have DBS, and any overuse activities, so sort of their lifestyle. All right. So when we look at medical management, like what that movement disorder specialist may do, we're going to have a wide breadth of some treatments that can be helpful, but we don't really have a cure. So here we're just managing symptoms, and that could be medication. That would include L-DOPA therapy. And this is sort of a complicated topic that we're not going to get into, but just keep in mind that depending on the person, and if this is their primary diagnosis versus a secondary diagnosis, so they have Parkinson's and dystonia, L-DOPA therapy can help improve the dystonia, or it, especially if they have Parkinson's, it could be enhancing or causing some of the dystonia. And so that's where the movement disorder specialist is really helpful. And some of the tools that we can use along the lines of medication tracking, symptom tracking, and getting the patient to really problem solve and have some insight about their symptoms to collect more information for the movement disorder specialist could help them tease out, is the medication hurting, helping, and then where do we go from there? And then Botox as well is a helpful treatment, not only for spasticity, like if someone's had a stroke, had CP, or has CP, something like that, but it can also be really helpful here in dystonia. And timing our therapy with their Botox can also be really helpful. And then depending on the person, if it's the right time and they're the right person, deep brain stimulation does have some good research around it for managing dystonia. And we don't have time to go into depth about DBS today, but there are some resources at the end that you are more than welcome to check out. And DBS can be used for a whole host of diagnoses. It works best for tremor. And so it also works really well for tremor-dominant Parkinson's, if that's what someone has. But we can also use it in different things like dystonia as management, and OCD or obsessive compulsive disorders and some other things. So, and that would be a surgery. So obviously there's a fair amount of risk, but for the right person, and if it's the right time in their diagnosis, that it's not too early or too late in the window, it can be a really effective treatment. So, and then obviously why we're here today, therapy can be really, really helpful. However, a lot of us are here today because we need some tricks. We need a bag of tricks around this, some tools, right? Because just managing it as if it were an orthopedic issue, like straight up torticollis or something like that, can leave us feeling frustrated and not getting the results that we want. So let's dive into that. When we look at the management, from a rehab or movement disorder specialist perspective, it really does take a team approach. this needs to be managed holistically because there are a lot of puzzle pieces here that need to come together. And I like to think of it as like 1% improvements in multiple areas overall. Like if we pick, 10 areas and improve it 1%, we're going to make a pretty big gain, a 10% improvement. And that's sort of the situation here. If we can make some small changes in multiple areas, we're going to get the best results. So if we look at the big picture, the pieces that are important include connecting the person with a movement disorder specialist for medication, Botox, DBS, so kind of working through that decision-making tree, what's going to work well for the patient. And medication management itself can be huge and really, really make a big difference. And then we also need to address the psychosocial factors. So these could be whole other lectures, but stress management, sleep is extremely important. And it's great to see how explosive this topic has been over the last couple of years. But I would highly encourage you to check out some sleep resources. But helping our patients improve the quality of their sleep can have dramatic results. And then nutrition and exercise, right? And we can intervene kind of in all of these areas and offer small 1-2% changes that can make a big difference besides just maybe our movement therapy and balance therapy, those types of techniques like therapeutic exercise, activities, neuro-rehab. Okay, so that said, let's kind of look at the rehab management framework. And again, I like to think of these as puzzle pieces or even a circle that kind of comes together. And I'm going to look at my patient and identify what are the physical limitations that I'm seeing with this dystonia. What are the motor control issues? What are the sensory issues? And then what are some of those psychosocial components? And then what are the autonomic components? So let's just put this into a case study so it makes a little more sense. So this individual did not have a formal diagnosis at evaluation. So this was a gentleman who we've actually been working with for a number of years. He came to us without really a diagnosis. In working with his general neurologist, he has a vascular Parkinsonianism. He does have some Pisa syndrome, torticollis, and we were concerned about a cervical dystonia. And it took a lot to convince the patient that it was worth going to a movement disorder specialist to consult with them, get maybe a more formal diagnosis, and get some management. So she delved into his medications, and as well, he did end up getting some Botox therapy. But one of the big concerns were through the process of this, he was having more cervical pain. He had been referred to a neurosurgeon, and they were talking about cervical surgery, which for him, he would have been pretty high risk for surgery. So if we can avoid surgery through rehab management, that'd be great. So if we look at his assessment, these were some of the things that were concerning. He definitely held his head, shifted to the right, and rotated right with a slight chin tuck. And he had done this for long enough prior to seeing us that he had started to develop like a torticollis. So it was extremely difficult he did not have the range of motion and flexibility to come back to midline. His perception had also shifted. So he leaned to that side and tended to have an inattention to the opposite side, the left. And that's where most of his falls were occurring, left and posterior. We also suspected he had some Pisa syndrome, kind of named after the Leaning Tower of Pisa, but that is like a perceptual deficit that really impacts some people with Parkinson's or atypical Parkinson's balance and posture. And so you can imagine he had lots of falls. that through some therapy were being managed. His walking balance was not great. He didn't walk a linear path. And then a couple other things that were of concern or were barriers included his cognition and his impaired executive function. So he definitely had a hard time with insight, judgment, problem solving, organizing himself and staying on task, or being able to set shift and go between tasks and come back to a task. And one of his personal kind of factors was he and his wife still live in their home, and she had multiple medical issues. But her cognition, at least when we began working with him, was much better than his. So she was sort of the brains of the operation and organizing things, although her mobility and health was fairly unstable. And over the last year, she had been in and out of the hospital. So he was alone a lot, or really taking care of her. And those caregiving duties did not allow for him to have as much time to manage his own health concerns. And he was very, very concerned with making sure he was managing her okay. All right, so gives you a little background and context. So if we look at his assessment through these puzzle pieces that would guide our choices in therapy, if we look at his physical limitations, he lacked the range of motion to move to midline. So we started with the foundation. If the structure is impaired, we went ahead and started to work on some soft tissue and manual therapy to increase range of motion and try to be able to get closer to midline. And then we tried to time that or continue that as he got Botox therapy. So Botox can take about 4 to 6 weeks to reach its peak effect. So as we worked with his movement disorder specialist, we tried to time our intervention to really hit that hard at his peak timing. So instead of maybe seeing him once a week, we tried to get him in 2 or 3 times a week, as well as implement an even more aggressive home program. But with some of his barriers and personal limitations, that was really hard. And then if we looked at the motor control aspect of things, this and the sensory were really where we got the biggest bang for our buck. And some things that might be a little different, or hopefully some new tools for you. So what this looked like, we did work on some postural re-education. So for this particular patient, we got him supine on the mat table. We did start to work into some soft tissue work, and we did a lot of movement prep to calm the nervous system. So we started with a lot of rocking and rotation. So we would just rotate side to side. We would rhythmically try to work into some side bending. Obviously, I have a lot more range of motion than he did. And we tried to do that passively at first. And then we would work on, again, lots of rocking and rotation, and not just at the cervical spine, but then we moved to the thoracic spine, and we would do some open the books and close and side lying. We would do some hook lying rotation with his knees to start to work down into lumbar. But each level of that spine is really important. And if we calm the nervous system or think about the strategies that help us reduce spasticity or rigidity, those principles work well here with dystonia as well. So lots of rocking, rhythmic movement and rotation. And then we could move into some manual therapy and work on mobilizing any vertebrae that were stuck, get some soft tissue work going so that we could hopefully lengthen some muscles. And then we moved into some isometrics. So we started both with rotation, with side bending, and really focused on those chin tucks. That was where we spent the most time. And then we used the mirror and some video therapy for feedback as we progressed those. So him using a piece of tape in the mirror, and when we do this via telehealth, we have them look right into the monitor and try to notice kind of where their head is in space. And then as we start transitioning into like sensory, we would just do this in different postures. So we would start supine, and then we would move into side lying over the bolster, or quadruped. And then we would also use different types of sensory input. So that could be our weighted vest, which is the balance-based torso weighting. We can talk about that in just a little bit, or ankle weights. And sometimes it would be ankle weights over the upper traps. Sometimes it would be wrist weights. If it's for lower limb dystonia, we might use an ankle weight at the ankle, and just 1 to 2 pounds. So not a lot of weight. And then psychosocial, like I said, we referred him to our movement disorder specialists. And then autonomic, we did spend a lot of time calming the nervous system with deep breathing, some meditation in preparation, some rocking and rotation. And then a graded exercise program. So this was really important for his Parkinson's as well as his dystonia. But one of the biggest challenges we had, he was not an exerciser. He was someone who liked activity and liked to stay busy and tinker with things or projects. But getting him to formally exercise was really hard and do it safely. So we did spend a lot of time on that. And we spent a lot of time on improving his hydration. He was one of those folks who always had low blood pressure, some orthostatic hypotension, and was kind of constantly dehydrated, never really drank enough. And so that was an area that we did need to spend quite a bit of time on and still spend time on. So let's talk about a couple of key things from here. So sensory reweighting can be really helpful for a lot of things. It works really well for ataxia. It works really well in managing different types of balance or postural control problems, lower extremity tremor, and it can work well as well here in dystonia. And so this is a certification program to work with the weighted vest or the balance-based torso weighting. So you can get more info here on Cindy's website. And there are quite a few different research studies that look at some of these different diagnoses and outcomes. But we strategically place small, half, quarter, sometimes a full pound weights in specific locations, either along the spine or the ASIS or pelvis, that help the individual with sensing or feeling proprioceptively where they are in space better without all the cognitive dual task processing. So this can be a really effective tool, but you don't necessarily like need to have a weighted vest. Again, I often will just go ahead and use ankle weights and play around with the placement. I might loop it over their belt, or a gait belt. I might place them and just kind of drape them over their shoulders while we're doing something, or ankle or wrists. So you have some options that you can play around with and see what works best for your patient. Okay. And then let's we'll go through just a little session that we did with a patient and this patient, and some things that work really well for us. So we do want to spend some time preparing the patient with some enhanced outcomes, and calming the nervous system. And depending on the patient, we can do that in several different ways. So we can start with a warm-up where maybe we take some deep breaths while we notice our head position in the camera. And the camera itself is an external focus of awareness cue. I can see myself. And we can also use other things that they can focus on. So we use a beanbag, or if it's via telehealth, we'll have them roll up some socks, place it on their head. And if their head position is changing, it's going to fall off. However, if they're in a good position, kind of like balancing a book on your head, it's going to stay there. And then we can use that throughout our treatment as just a cue so that they get some feedback about how they're performing. And it's always easier to focus on something outside of ourselves and learn a movement versus focusing on something inside of ourselves, like lifting our chest or pulling our shoulders back or something like that. So that works great for no matter who you're working with, athletes, people with Parkinson's, or here in dystonia. So we had the patient warm up, and you would want to start or grade the activity in the position where you get the best normal movement. So oftentimes that's starting supine, right? But we'll start seated for today, and I would encourage you to join along with me today. Get moving a little. So I might ask them or cue them to notice what their head position is in the camera. We could go ahead and put that sock on there, and then we can start with either hands on their lap, or we could start with some other grounding techniques. We'll go ahead and start with hands on our lap. We can also lace those fingers, bring hands to our head as a grounding technique, and then just take a deep breath in. Maybe they close their eyes and exhale. And then take another deep breath in and exhale. We could take another deep breath in and exhale. And I might just cue them that they can expect to see some really significant improvements in their posture and their movement as we work on improving their head position. And then I want them just to pay attention to maybe what happens to that sock, or if it's easier for them, notice where their head is in the camera or in the mirror. I think the sock works better than the mirror. And if you're doing telehealth, I think it can be really helpful to just keep an eye on themselves in the screen. And then we might start with pairing some deep breathing with some posture re-education. So we might power up, inhale, squeeze those scaps together, exhale. We might do some cat-cows just to get some flexibility going, and then add that scap retraction. And then we can also start to calm the nervous system with some rocking. And then I'm going to keep that beanbag on my head, so I keep my head relative to gravity, and you can see I'm getting that nice C curve and writing reaction that I would want. And this in itself could be pretty hard for them. And then we can come back, take a deep breath, and maybe we rotate. So if needed, you might have to just warm up the nervous system and take this away if this is getting too challenging and you're not in a position to get them supine, like on a mat table or something like that. And then we can address posture in sort of that graded position. So oftentimes, I'll kind of show you real quick our flow as we lay down on the mat. So I might have them come down onto a mat table or the floor and start supine. If they can't reach the mat or the table, depending on where they are, I may have to bring them up, right? And then we can start with some rotation, some gentle side bending. We can move to the lower spine and do some hook lying. We could also go ahead and add a twist with the arm, or we can go ahead and move to our open the book and close and mobilize that thoracic spine. And then we can go ahead and move into some chin tucks and isometrics, right? Or work on extension. So extension can be helpful with maybe some bridging. But then I do want to get them in some different positions. So if this particular patient tends to hold their head oriented to the right, then I would get them in left side lying. And then I might ask them either with or without support. So they may need some support with some props under their thoracic spine. I may ask them to just start to work on some side bending and hang out here for a little bit. And again, we're still really kind of preparing and just addressing posture and some of the sensory components and perceptual components here. And then if we can, we'll move maybe over a ball. So might take my therapy ball, or a peanut works really well here. And I can modify if that was a little too hard, or it can make that surface more unstable, right? And I can ask them to go ahead and put more weight bearing through the arm, come up. So you have a couple different options. And then you can move to quadruped, and sometimes that ball is helpful for support. And I can ask them to either start moving into their chin tucks. We can start to rotate into the direction that's limited. And we can start to work on some great rocking and rotation here. You can even start with some thread the needle, coming down. And then we can always start to work on more extension at the lower spine, because if their lumbar spine is really tight, we may just need to do some rocking back and forth into child's pose. And oftentimes they're lacking full hip extension, so we may need to work on going ahead and increasing strength and extension for gait, or work on some stretches at the hip flexor. And you guys know how to do those, so there's lots of methods. And then I'm going to go ahead and bring this up. We often will start to work into some standing and pre-gait activities. And so I will have them stand close to the wall here. And this is a great place to use that beanbag again. But I have my foot about 1 inch from the wall, and I'm going to have them reach up and shift their weight and try to bring their whole body to the wall, and even their head to their ear to their bicep, and come back. So this weight shifting at the wall is going to prepare them for normal balance. It's a great pre-gait activity, and it gives them an external focus of awareness cue. I'm bringing everything to the wall. And I could just focus on the side. Again, if they're oriented right, I might just do the left. But it can be helpful to do both sides. And then we often will also work on a staggered stance, like a boxing stance. So 1 foot forward and 1 foot back. And then bringing my belly to the wall and reaching up. And I really want to get that nice toe off from my foot. So you see my stance, I want to see them really push off this back foot, reach high, and come back. And again, this is a great place to put that bean bag on their head so that their head stays in midline as they're preparing and weight shifting to walk. And you could do this with, we have a grab bar at the wall for them to hold on to, but you could also do this in their walker. So you have a lot of options, but that's a great way to kind of build the task and prepare for more dynamic activities. And then that's an easy home exercise program as well. And then throughout that, we're just cueing the patient, how did that feel? If they have appropriate insight and judgment and cognition, what could you do different? What might you want to do next time? Or did you notice if this fell off your head? If it's someone with pretty poor cognition, then I would just move into errorless learning. So you don't give them those insight problem solving cues, but instead say, let's try this, and you rearrange the task for them to find success. And obviously keep it simple is helpful. So, okay. So those were some of the things that worked really well for this patient, and for a lot of our virtual patients. Those were some things that we could easily do with them in a safe way. And if we think about what's next, or some more food for thought, really applying the optimal theory of motor learning is going to be key. And I would say this is honestly true for all of our patients, but it works incredibly well here. And this is what I was talking about with enhanced expectations and those external focus of awareness cues. And then making sure we give the patient autonomy. And we may not always use this language around it, but most of us are hopefully doing this already, but we really want the patient to kind of drive the car, so to speak, and make decisions about what's going to work for them, and really kind of take the bull by the horns, kind of take control of what they're doing. So kind of asking like, hey, would this work for you? Or here are 2 suggestions I have that I think would make a big impact. What do you think would work for you? And having them choose and really take ownership of that, we're going to get way better outcomes when we do that. And then building up their expectations or enhanced expectations. This is what we can expect from it. And I think if we apply the right amount of repetitions, which hopefully you saw that on the slide, but we do need a lot of repetition. So hundreds of repetitions, which means, throughout the day, hopefully maybe they're doing 10 here and 10 there. And then those external focus of awareness cues are really key, because that's going to give them the feedback on their performance, so they know if they're practicing it correctly. It's also much easier for them to learn. So anything that I can focus on outside of my body, so touching my hip to the wall, not letting the beanbag or some socks fall off my head. Maybe we put a tissue box on the floor and they have to step over it to know that they took that big enough step or really shifted their weight. So things outside, bring your belt buckle to the wall. Those are the types of cues that are going to be really helpful. And then just preparing the brain, training it, and addressing any of those underlying factors are where we're going to get the best results. And so to address underlying cause or factors, those are the things that we just walked through in a case study, but I just want you to have it kind of bulleted here. And when we think about training the brain, if we have overexcitability, then we want to inhibit that, create more calm and inhibit abnormal movement. And so when we're thinking about it in this structure, we can use those position changes and change of sensory input. So again, the weight, but some other things that work well include vibration, kinesiotaping as well, or TENS. And then we want to train the normal movement pattern. So progressively progressing that difficulty and really trying to avoid the abnormal movement triggers. And so you might have to progress a little slower than you would with someone else, and just kind of watch closely. Again, external focus of awareness cues, and then improving sensory discrimination can be really helpful here because of that sensory cortex involvement. So this could look like, while you've got that person on the mat table, you may be giving them those small little touches, light touch with like a feather or something small. Where am I touching you now? How about now? And then working on that head relative to vertical and writing responses is really important. So that's what we did seated. As we were rocking side to side, I'm keeping my head relative to vertical. I don't want them to be the airplane, right? And so that external focus of awareness cue helps them cue into it without you over explaining it. And you can progress that in multiple ways. So we could do that. That's kind of what we did a little bit at the wall. And then we can do that on a rocker board, on an incline, and in different postural control positions to try to get that head to be relative to gravity. And then can they isolate or have discrete motor controls? So, and this is what we did on the mat table. Can I keep my head still as my upper trunk is rotating? Can I let my legs go and keep my shoulders and head still? So we can kind of interweave some of the things that we're doing for multiple purposes. And then lots and lots and lots of repetition, like hundreds of repetition per week are helpful. And then just looking at addressing underlying factors. This is kind of the framework we were discussing. So strength, we're looking for imbalances. Usually extensors are going to be much weaker than flexors, and flexors tend to be much tighter. And that whole spine is going to influence any like cervical dystonia. And then we can address biomechanics. What activities make their posture or their symptoms the worst, and a lot of times it's going to be working against gravity, sitting, standing, gait. So then we just need to dial it back to get rid of that abnormal movement pattern. And you guys know how to treat balance, but we really want to work on those writing reactions and anticipatory postural control and proprioception. So some of that sensory weighting, like the 2-pound ankle weights, help, or weighted vests really help with proprioception. We can work on anticipatory postural control. If you guys aren't familiar with Clock Yourself, it's an app you can put on your phone that helps us with some stepping responses and is a fun game you can play in therapy, or it's a perfect home exercise program. The concept is we're standing in the center of a clock and she calls out 12 o'clock. We take a step like we're catching ourselves and come back, or 3 o'clock and step and come back. So that's a fun and easy one. And I would encourage you to check out the app Clock Yourself. And then we can look at nerve mobility if we need to, and thoracic spinal mobility, and for any common upper limb tension patterns. Okay. And then holistic approach, just a reminder, exercise, nutrition, hydration are really important, stress management, and then mental health resources and management. So just a reminder to put, and sometimes it's just putting language around it. If someone is not ready to change some of their health behavior habits, like start exercise or drink more water or give up coffee or drink less coffee, right there, we're kind of like, okay, maybe we shouldn't go down that path because we could actually make it worse. Or you just want to guide and kind of put our intervention to match where they are with their readiness to change. Pre-contemplative, contemplative. We've got a whole talk about this that you can check out that I do. But we would just want to be aware of their readiness to change, their self-efficacy and resiliency, and just help them move up that path so that we could address some of these other things that will make a big difference. All right. So some of the things that really helped this patient, I mentioned he had some barriers at home. We were able to get him to meet with a case manager who helped them decide whether or not they wanted to stay in their home or sell and maybe move to an independent living facility or assisted living, which they just did recently, which was a huge, or I think will be really, really helpful. Once the stress of moving and being in a new place settles down, and now that they have more support, I think we'll be able to even further improve some of his outcomes. All right. Whew. That is a lot, but we'll do some questions specific to any of that stuff at the end. We just work with adults who have dystonia and dyskinesia, so I won't speak to any children's or very specific diagnoses. We're just going to chat today about cervical dystonia and focal or lower limb. Okay, so let's talk about dyskinesia. All right, so dyskinesia is different. It is uncontrolled involuntary movements. And I like to think of it as too much movement. So if you think about like Michael J. Fox, he's kind of moving all over the place. And so we get almost too much movement. I overshoot and undershoot the movement. And so I have a hard time maintaining the posture that is going to help me maintain my balance. And this is typically secondary to something like Parkinson's and the use of L-DOPA therapy. Not everyone with Parkinson's, though, is going to get dyskinesias. And so that's important because oftentimes there's some bad press on that. Like people come in expecting it, or maybe are hesitant to start medications because they are afraid that they're going to get dyskinesias, but then they're not optimizing their movement to exercise, which is even worse. So it can be helpful to remind them not everybody gets dyskinesia. But certain profiles are more likely. So those could be people who are young onsets. They're diagnosed in their 40s or 50s. If they are underweight, and then women as well. Okay. And then let's just talk a little bit about the medical management. So, which medications we choose when dyskinesia is an issue. The movement disorder specialist, again, is really, really helpful in this situation. It's what they do all day, every day. And medications with Parkinson's or, again, dyskinesias are really hard. So, we really want to look at how we're dialing in the timing of their medication and what they're doing, maybe adjusting the dosage of the L-DOPA, carbidopa, levodopa therapy. They might add amantadine or some other helper medications like Calmtan. And sometimes DBS can be really helpful for this patient. But then obviously we also want to manage their balance and movement with physical therapy or occupational therapy. So again, similar framework here. All these puzzle pieces really need to fit together because those psychosocial factors just amplify dyskinesia tremendously. So we can get a lot of bang for our buck by addressing stress, sleep, nutrition, and exercise. And if this individual is taking oral medications and is super constipated, they are not absorbing those medications in an effective manner. So, just addressing constipation and hydration could totally change their presentation. So I just want to keep that in mind, okay? So if we look at a case study, this is an individual that works with us who was diagnosed actually about 15 years ago. So he was technically young onset. He's 64 now, and he came to us during COVID. He was not utilizing his regular resources. He had a decline in his mobility, his gait, his ability to exercise. He was having some falls. His risk was pretty high. And he's having a lot of difficulty with his medications. And you can see here, it kind of has a pretty complex medication schedule. So this is what his doctor was recommending. And the timing of his meds, was really challenging. So he's taking carbidopa, levodopa, which is your typical medication for Parkinson's. And because he had been taking it for a number of years, he really noticed when he was wearing off. And in the morning, he kind of needed more to get him back up to a steady state or an on state. And then throughout the afternoon, he could taper that to about every 3 hours. And then one around close to bedtime. So, but what we were finding is he was having a lot of dyskinesia at certain times of the day. And so we did some medication management and training with him. And this is a great task, both for PT or OT, for us to help collect more information for the movement disorder specialist as well as for us. And we use what's called a medication tracking sheet, or the dyskinesia on-off log. And you can find that on the Davis Finney Foundation website under worksheets. And in their Every Victory Counts manual. And it just looks like what we have here to the side as this, and basically they just put a check mark when they take their medication, like a little X at that time, and then they would rate their dyskinesia severity 0 to 3 throughout the day, and their Parkinson's symptoms 0 to 3, 0 being none, 3 being the worst they've ever had. This usually warrants a little education discussion about what dyskinesia is and how it feels in their body and what it looks like, and then what are their symptoms. It may be that they get more tremor. It may be that they get really slow or stiff, or they notice their posture is really flexing forward, or their feet are really shuffling, right? So oftentimes we have to do some problem solving with them so that they're in tune with what their symptoms are. And basically what we found with this individual was that he was having more severity of his symptoms early in the morning, and taking some rescue medications that are inhaled forms of carbidopa, levodopa. And that was then getting processed in his body and causing these, if you kind of look at our chart here, causing these peak dose dyskinesias about an hour or two later. And oftentimes that was when he was coming to therapy. And so he would have just this like up, down, up, down. And and that's sort of the basic premise of where we think some of the dyskinesia is coming from for an individual who's had Parkinson's for a longer period of time and is at more risk, is that, the longer that they are on the medication, that window, that timing window in blue tends to narrow. And so it's much easier to cycle between off and peak dose dyskinesia. It happens much more quickly or sooner. And so by giving his movement disorder specialist and him kind of trying a few things at home with this information, he was actually able to smooth out this up, down with just changing the timing of his medication in the morning slightly. And it worked really well for him, and his dyskinesia has been much better managed. But that said, we also addressed his dyskinesia in the clinic and worked on his balance so that when it was happening, he had tools and strategies. And what worked the best for him was some of the things that we just did on the mat a moment ago. So we did a lot of work on his posture because a lot of the dyskinesia was happening from his head. And if we could improve proximal control, we got better distal control. So we worked a lot on posterior chain strength, improving his thoracic and lumbar and hip mobility, using the things that we just showed you. We did a lot of posture re-education with chin tucks and our power moves progressions, and reciprocal coordination to calm the nervous system. So moving like one leg and then the other, one arm and then the other, or uppers in the opposite pattern as lowers. And then we did spend a lot of time working on his balance. So anticipatory postural control, some different stepping responses, and being accurate about foot placements. So we use different external focus of awareness cues, like a big foam colored tile that he can step on, and then progress to something that's auditory, like a whoopee cushion he could step on. Or we have some foam clicker feet that click when you step on them. And so then he could just listen versus have to look. And the target got more exact while he did something like the clock yourself. And then we did work on his freezing and festination with a lot of our 4S strategies. So we stop, we spread our feet, we rock or sway, and then step. And then what worked really well for his walking when he had a lot of extra dyskinesia was we've got a Post-it on the wall behind me. I'd ask him to look at that Post-it note, keep his eyes on it at eye level versus down at his feet, and walk. And by just working on gaze stabilization and keeping his gaze stable on something like a picture on the wall, the exit sign, a Post-it note in his home, that made a huge difference. And then we used some of the same strategies we just talked about as well. So sensory weighted vest, 2-pound ankle weights worked really well for him. Increasing proprioceptive input with a lot of weight bearing and closed chain positions. And we did a lot of boxing with vibration and proprioceptive input. So using gloves and mitts and a punching bag. That worked really well for him, and working on control and grading his movement with that. And we worked closely with his movement disorder specialist with his medications, and we showed you the medication tracking sheet. That made a huge difference. And then we did a lot of autonomic nervous system calming. So we worked on some diaphragmatic and deep breathing with him. We worked on our 4 count in, hold for 7, out for 8. Or at least extending the exhale, and started to move him into our community exercise class with yoga, and talked about some meditation apps as things he could do at home when he started to get amped up or have more dyskinesia and get anxious about it. We did need to work with him on a graded exercise program for his Parkinson's and his dyskinesia. And it was great. The other day, he's like, oh, when I do my exercise, I feel so much better. I was like, yeah, right. So we worked on building up 30 minutes for him on the bike was the safest. And then we started to implement some intervals. And then he had every other day. Well, we started with every day and progressed to every other day, some of the balance and strength home exercise program, and then trying to transition him into some group classes like yoga and boxing, where he's having fun, he's socializing, and he's kind of getting some more progressive difficulty, but support to keep it all going. And then same for him as well. We really focus on increasing his hydration and water. He's doing better with that, and his blood pressure is better. And now we're kind of focusing more on sleep and sleep training and habits. And those things really worked well for him. So this is what we were just chatting about. It's just in a little more detail if you want to look back at it later. And just to kind of bring us to the end, when we look at dystonia and dyskinesia, while they are two very different symptoms, there are a lot of commonalities. Definitely referring a patient to the movement disorder specialist is helpful. Optimizing their medications and working on some medication management, and just teaching the insight into the awareness of symptoms. We gain a lot of information from tracking. Is really, really important. And then obviously for both, a holistic approach is important. And then just looking at our puzzle pieces, right? Physical limitations, somatosensory issues, right? And going through that framework can help guide us to what we might want to really focus on with them to start. But obviously they are two different things, right? We can have too much movement, or we get an abnormal twisting and contraction and then holding there. So, all right. We've got resources for you. I know this is never quite enough time. I feel like I could talk all day with you guys. So I appreciate you hanging in there and being a part of this. I'm going to come back to our questions now and try to answer a few things. I don't think I see any new questions. So feel free to type questions in, check out resources. And you guys are always welcome to email me as well with additional questions. So we do have more resources that go into more depth than you get CEU credit for. So if you are interested specifically in Parkinson's, we have quite a few. I teach a couple courses on Parkinson's management that are virtual or webinars or recordings. And then we do have a class as well on how to help change your patient's health behavior habits and get them to do things like exercise in their home exercise program. So where we dive more into readiness to change and resilience and self-efficacy. And movement disorder specialist, that is actually their title. If I'm answering a question here. So we can have general neurologists, and then a movement disorder specialist does an additional 2 years of fellowship in basically degenerative disease, so Parkinson's, dystonias, and that's all they see. So depending on where you are in the country, they can be easy to find. I've got 5 or 6 here in Denver that are great. And if you are in a very rural area, that could be extremely difficult to find. However, a lot of docs are doing telehealth now. And so that might be an option. You can definitely start with the big clinics like Mayo and Cleveland Clinic and the Muhammad Ali Center, or University of Colorado. But movement disorder specialists are their own specific physician, and they're a subsect of neurology. So they are not a physiatrist. It is a different focus. And quick question about Ritalin and PD. Yeah, we do have some movement disorder specialists that will prescribe that for fatigue and Parkinson's and helping to focus attention. And so we do have a few patients that will utilize it, and there's pros and cons. So it's going to depend on the patient. If we look at typical idiopathic Parkinson's or tremor dominant Parkinson's, those folks, dopamine drives the frontal lobe and our ability to maintain attention and focus. And fatigue is a big non-motor symptom. So some of those folks are being prescribed Ritalin, and again, pros and cons. So it's really, does that work for the patient and their lifestyle? But that is a thing. And then just thinking, just a question about it looks like there's a question about using a solid floor surface versus bed or soft surface. You got to work with what you got. Like if you're in home health, obviously, you may not have an option. And so you just sort of adapt or modify it to work for the patient. And again, every patient's going to be different. So it's great if you can use something like a mat table or a yoga mat on the floor. Just keeping in mind with that patient, how is that going to affect their balance and their movement? It's always going to be a little easier to do some of bridging and those types of things against a more solid surface. So you might just have to get creative to get the movement or to get what you need. Okay. A couple of other questions. When we're working on, we do have some patients that do have a lot of pain associated with different positions. And so, I think when we think about normal movement, we definitely want to help them find as pain-free a position as we can first. And we may need to use some sensory tricks like TENS, vibration, deep pressure, and a lot of nervous system calming to help decrease that overexcited nervous system so that they can get into a state of reduced pain. So I'm thinking about one patient in particular who also kind of everything really hurt or in their mind flared up their symptoms. And so we spent, for him, we were able to do some supine on the mat table, even though there was challenges in getting into the position and getting comfortable in the position. But we really started with dim lights, closing the eyes. I matched my voice and demeanor to a calmer nervous system and did, again, some deep breathing to start, some deep pressure over key areas. And so that might be some grounding techniques like a weighted blanket over the patient or just like a thick folded up blanket over their torso. And then as they were able to tolerate that, we started with some gentle rocking that was passive, and just started to work into, again, calming the nervous system. And we had to spend a good portion of the session preparing to move. And a lot of that was around calming the nervous system. And then teaching them to do that for themselves at home. So downloading a meditation app on their phone that they could do seated or maybe laying down, whatever the position of their choice was, and focusing in on their breath, and then focusing in on and doing a little tracking about how they felt before. So pain before and then pain after 0 to 10, and helping them correlate, when I do this activity, like deep breathing or this meditation app, I feel better after. And then how can I make that a daily habit and start with 5 minutes maybe before I get out of bed, or 5 minutes when I get into bed, or 5 minutes, whatever habit we can pair it with, like at breakfast, lunch, and dinner. And then what are things that maybe trigger and start to make me feel more pain or tension. Triggers could be stress related. I'm watching the news. Triggers could be movement related, right? But we would want to help them start to identify their triggers. And maybe we do a little tracking around that, like different times throughout the day. What was I doing? Like a little pain log. And, what was my pain? What was my pain after watching the news? Or what was my pain after being involved in a stressful situation with my family, or a stressful phone call, or a stressful work situation? We can also start to look at how their sleep as well is impacting that. But helping them associate those two things together is helpful. And then here's what I can do about it. I can just sit quietly for a minute and do some deep breathing. That's a place to start. And then that would open the door for more movement therapy. Okay. So TENS, so we're talking about E-stim, and TENS is a setting on E-stim. And weighted blankets, yes, could be helpful, but we just want to be mindful of like how we're using them. I have found more specific targeted weights either to the upper trap or to the hip flexors, or if it's a lower limb dystonia, to the ankle itself, of 1 to 2 pounds is really helpful. But if we're just going to calm the nervous system, you can absolutely try just a general weighted blanket. And then deep brain stimulation, I can't give you just like a general success rate. You would have to look at each specific surgeon as well as different diagnoses. And really it's all about the right patient and the right time. So if we do it too early or too late, we're not going to get good outcomes. And it's also, if we're looking at outcomes, what is the patient's expectation of what's going to improve? It's really only going to work as well as their medication works. So medications help rigidity or stiffness, it helps slowness of movement, and it helps tremor. So medications don't help balance. That's why we've got therapy. Yay! So deep brain stimulation is not necessarily going to help therapy or help balance. So there's a lot of things you would have to look at specifically related to deep brain stimulation. But there are some good resources out there that you can go ahead and check out if you have a lot of patients with that. Okay, I think we are getting to the end of our time. And I think I've answered the majority of the questions. Thank you guys so much for being here. We really, really appreciate it. And it's always nice to have a conversation with you. Have a great rest of your day.